You're welcome to my channel. Here is a quick presentation on how to manage methicillin-resistant Staphylococcus aureus outbreak. For full info on MRSA, you can click on this very link. That will take you to full info on methicillin-resistant Staphylococcus aureus. But for preventive measures and surveillance, because when there's an outbreak, there must be surveillance. And of course, we don't want that to happen again, right? You can click on this very link. MRSA outbreak. Before going deeper, let's understand some facts. The MRSA could be hospital or healthcare associated. In that case, it's tagged as bloodstream infections. Although, if you listen to my full presentation, based on the link that I provided earlier, I gave more explanation on this, that it doesn't have to be bloodstream before it could be hospital or healthcare associated. So if it's happening within the hospital, then it could be from contaminated devices, procedures, surgeries, IV lines, tubes, probes, and so on. Even from implantable devices or artificial joints, and the list goes on. But it may not be hospital associated, it could be community associated. In that case, it could be tagged as skin and soft tissue infections. Also, again, if you click on that very link, it will take you to full info on that. So it could be boils that will be spreading from skin to skin. Now, the two, either hospital associated or community associated, will cross as per location, because you can discharge someone from hospital into the community and you can admit someone from the community to the hospital. Though I don't want this presentation to be long, but I need to explain this fully. We will make the full and definitive diagnosis of healthcare-associated MRSA or nosocomial infection involving MRSA after 48 hours on admission. Meaning, we cannot admit someone right now and within 24 hours, and we'll say, oh, there's MRSA in such a patient, so it is hospital acquired. No. What we are going to do is within the first 24 hours, we will swab the anterior nerves, the groin or perineum, depending on what you call it. If the result is positive, that is not hospital acquired. It means the person has brought this from the community. We expect the result to be negative. So if the result is negative within the first 24 hours, then after 48 hours and beyond, is now positive, then the patient got it within the hospital. So we will make that diagnosis after hospitalization in anyone without such MRSA before being admitted into the hospital. It can be acquired during surgery, and then the patient is discharged to the community. The individual may present with severe skin and soft tissue infections, bloodstream infections, pneumonia, multi-drug resistant infections. Community acquired MRSA could present with different types of infections: boils, soft tissue infections, sepsis, infective endocarditis, necrotizing pneumonia, osteomyelitis, and urinary tract infection. The possible places where outbreak can occur will include prisons, that is correctional centers, banks, group homes, daycare centers. Among this group, IV drug users and sports teams. When there's outbreak, first thing first, there must be proper communication. The floor manager will inform every member of staff, all doctors, particularly infectious disease experts, will be involved. This is their field. They will take control here. All technicians should be informed whether certain procedures that could be invasive. The technicians should know that they are dealing with this. Protocol should be put in place with a written order. This is more important than verbal order because someone can inadvertently forget. If we must transfer the patient with MRSA to another unit or another hospital, then the new unit or hospital must be told. EMS that will handle these type of patients must also be informed. We will definitely inform the infectious disease specialist. Many of them are available worldwide. They will help us out. If one patient in a room is MRSA positive, then any staff that will deal with them, doctors, nurses, healthcare aid, anybody, must have PPE. All patients in that room must be screened. There should be separate vital signs machine for the affected person. We should not use anything we use on that patient, we should not use it on any other patient. All gadgets should be isolated. When it is even the time to get food, the affected person should just call on phone, should not be filling form, menu to get food, because we don't want the paper he or she will fill to be taken to the kitchen and then spread from there. Commode should be by the bedside for his or her use. If one patient in a room is MRA positive, the other things that we can do would be to place a sign at the door that is going on in the room. Place a sign by the curtain if the person is in a shared room, meaning 3 or 4 people in one room, but you cannot do physical examination without drawing the curtain, right? So we'll place a sign by that curtain. Prevent too many visitors at a time, and all visitors must have PPE while visiting. A separate room, a separate room, a separate room, I repeat, will be better. Is that not a blessing in disguise, eh? Now, treatment. The treatment will be done empirically, meaning we will base the treatment on what we are suspecting to be the cause in that region. So before microscopy, culture, and sensitivity result will be out, we will start treatment. If we are dealing with boys, is a rule in medicine, particularly in surgery. When there's an abscess, you have to have incision and drainage. When it is cellulitis, quickly, we must grab intravenous antibiotics. Still on treatment, we should get something. Get what? If we are able to find the needles or the specific source of this trouble, we should get rid of it. We must institute prevention protocol. That is why I've provided a link if you want to know more about surveillance and prevention of MRSA. We must limit the spread and embark on treatment immediately. Empirical oral antibiotics will be reasonable if we are dealing with mild cases, particularly localized cases. So it must not be a systemic infection or the term bloodstream infection. So mild and localized. Once it is systemic, no oral antibiotics immediately, no. Then we can choose from any of these, but this is just, from me, it depends on what is obtainable in your jurisdiction or what the protocol is in your center. If you want to know more about Sectra, you can click on this, linezolid, this will take you there. Clindamycin, I have cell representation. Lefluoxacin, this will take you there. But don't use fluoroquinolones in skin soft tissue infections because of the probability of resistance. Still on treatment empirically, we cannot use oral agents under some conditions. In that case, we'll go for intravenous antibiotics. For example, in systemic infection or bloodstream infection, we'll go for intravenous antibiotics. If the soft tissue is extensively affected, we go for intravenous antibiotics. In cellulitis, in fact, we will see that cellulitis will be rapidly progressing. We go for intravenous antibiotics. Also, if someone has been on oral antibiotics for more than 72 hours and there's no improvement, then we have to change to intravenous antibiotics. And in someone that is immunocompromised, then we go for intravenous antibiotics. Another patient that is on prosthetic devices and the device is pretty close to the infection site, we should use intravenous antibiotics. Useful agent that we may choose from will be this, although there's nothing rigid here. It depends on what is obtainable in your center. So you may choose any of these. Particularly, telemvaccine is approved by United States FDA for severe skin and soft tissue infection. Now, finally, if we must do all those stuff above, what will you then expect a unit that is done with MRSA in 5 to 10 patients to do? I'm asking you the question this time around. Please supply your answer or answers at the comment section. With that, I've come to the end of this short presentation as per MRSA outbreak. All over the world, brilliant doctors and nurses are handling this perfectly. I have just brought this out as a recap, particularly for the beginners. For full information on MRSA, you can click on this very link. Thanks for listening. Remember to share. Remember to subscribe to my channel. I appreciate that.